Hello, good morning, my friends from the Asian Oceania regions, and also good morning, my friends from the North America and other places on the western side. So, welcome to the finale session of the AsiaSafe webinar on the optimization series. So today, this is like the wrap up of the session that we has been talking on the optimization strategy for almost 5 months, and this is the last one on this series of this year. So today we are going to talk about how can we make this thing happen. For the optimization, how can we bring people together, not only radiologists, but also the technologists and medical physicists to make this strategy happen, make the optimization happen for our patients and help improve the healthcare and image quality in our regions. So before we go that far, first of all, I would like to invite Dr. Jamari Sopon, who is the AOSR president, to give the welcoming speech.
Thank you. Good evening, good morning, and good afternoon to all our colleagues joining us from across the Asia-Oceania region and beyond. It is my great pleasure to welcome you to this important session of the AsiaSafe webinar series 2025, Making It Happen, Team-Based Strategies for Radiological Optimization. This webinar is not just another academic gathering, it is a call to action. Today, we focus on practical team-based strategies that empower radiologists, technologists, and medical physicists to work together in optimization of radiological practice. Our shared goal is clear: to improve image quality, enhance patient safety, and raise the standard of care across our region. We are honored to be joined by an outstanding panel of experts. Professor Samuel Brady, Chief Clinical Medical Physicist from Cincinnati Children's Hospital Medical Center. Mr. Steve Lacey, Director of Education, Australian Society of Medical Imaging and Radiation Therapy. Professor Kosuke Matsubara, Department of Quantum Medical Technology, Kanazawa University in Japan, and Dr. Dennis Cho, Chief of Service and Consultant Radiologist, Kwong Hospital, Hong Kong. He's now AOSR President-elect. And Professor Jeong Min Lee, Department of Radiology, Seoul National University, South Korea. Also now AOSR Interim Honorary Secretary. A special note of appreciation goes to Emeritus Professor Kwong and Associate Professor Nucharin Supakun for their exceptional leadership as moderators throughout all episodes of this series. Your dedication and effort have been instrumental in making the AsiaSafe webinar series 2025 a success. This episode makes the final session of the AsiaSafe webinar series 2025. Over the past month, we have explored critical topics from those optimization and modality-specific strategies to implementation in clinical practice. Today, we bring these discussions together, focusing on actionable team-based approach that can transform recommendation into reality. Let us use this platform not only to learn, but to inspire change in our institutions and communities. Together, we can make radiological optimization a reality, not just a recommendation. Thank you once again for being here. I wish you all a productive and engaging session. Thank you. Back to moderator, please.
Thank you so much, Dr. Jamari, for wrap up the purpose on what we are doing today. So the next one, I would like to invite Professor Ng, AsiaSafe chair, to give some opening speech and welcome message for the team. Thank you.
Yeah, thank you, Dr. Tanya, and Chamari as well has welcomed you. Wonderful. As the chair of the AsiaSafe, I'm very proud to say that this is a unique occasion. We gather all the practitioners, stakeholders, radiologists, radiographers, and medical physicists as well to talk about this very important topic on optimization strategies in radiological practice. I don't think that any other organization have managed to gather all this together. And thanks a lot to effort, Dr. Tanya, to bring all these people together. And I know particularly most of them, my colleagues and friends I work with. And we, as Dr. Chamari has said, this is a finale. All this whole year of various optimization topics, thanks to Dr. Sam Brady, who has taken the lead in this and come to this series. So it'd be good that we look back what we have set out to do, and if we have met our objective. I'm sure it is. So we look forward to this exciting panel or forum today. Thank you once again.
Thank you so much, Professor Ung, for the welcoming speech. So let me, first of all, give the formal, proper introduction to our speaker on the presentation slides, and then I will tell you guys and the audience about the formats that we are going to do today, which is a little bit different from what we have done in the last 5 webinar series. So first speaker today that we have Dr. Samuel Brady, who is a medical physicist from Cincinnati Children's Hospital. He's a professor there and also the fellows of the American Association of Physicists in Medicine. He has a lot of international experience, including as a part of the IAEA as an IAEA expert in helping and developing the DRL in in the country, other countries, and also he is a member of the IEC to develop technical standards for the safe performance of the CT medical equipment around the world. He is also the vice chair of the Emergently Alliance and also the chairman of the ABR exam for the radiologist on the physics portion. He is also the chair for the AAPM Annual Meeting Education Program Working Group and also the member and ad hoc committee for the Artificial Intelligence Bootcamp for the Physics. And thank you so much, Dr. Bentley, for helping throughout the series. And the second person who is the medical technologist, Mr. Stephen Lacey, who is a director of education from the Australian Society of Medical Imaging and Radiation Therapy. And he is also the director of education from the International Society of Radiographers and Radiological Technologists, ISSRT. He has been a radiographer in Australia since 2002 and as a lead clinical educator in medical imaging at the Royal Children's Hospital in Melbourne and also the Allied Health Clinical Education from 2009 to 2024. And he's also the founder of a podcast series for medical radiation professional called RadPod. So which means I think people can follow you, right, Steve, if they want to listen to you on RadPod. And he is also the ISSRT Board of Management as a Director of Education since 2022, and also Director of Education for the Australian Society of Medical Imaging and Radiation Therapy. So it's so good to have you as a representative for the panel discussion on as a perspective on the technologies. Welcome. And the next person that we have here is Professor Kosuke Matsubara, who is a professor from the Department of Quantum Medical Technology, Kanazawa University, Japan. He is a PhD in health science, Kanazawa University from 2008. He is a certified medical physicist specialized in medical imaging and radiation protections. He is has more than 150 peer-reviewed articles and on the radiation measurement and protection and CT. Oops, did I lost my screen? I'm so sorry. Yep. Sorry for the technical difficulty. And he is also the vice representative for director for the Japanese Society of Radiological Technology. and a member of UNSCARE, which is a small group of the expert on the medical exposure. So we are so nice to have you as a representative for the medical physicists in this region to discuss this topic with us. And we also have the radiologist representative, Dr. Danny Cho, who is a chair of the service of Department of Diagnostic and Interventional Radiology from Kwong Hospital. He is an honorary clinical associate professor of Department of Diagnostic Radiology from the University of Hong Kong, and he is a president-elect of the ASRR. He is like a vascular and interventional radiologist by training, and he was a vice president of the Hong Kong Society of Radiology. And then we also have another like a radiologist representative, Professor Jeong Min Lee from the Department of Radiology, Seoul National University Hospital. And he is currently the interim honorary secretariat of the AOSR. He's a well-known speaker and scientists and radiologists who do more than like a 500 scientific paper and more than 300 invited lecture. He's also the esteemed member of the editorial board of the Radiology, Cancer Imaging, Abdominal Radiology, Liver Cancer, and the KJR, Korean Journal of Radiology. He is a vice president of the ASAR 2025. He is a chair of the educational committee of the AOSR from the term of 2023 to 2025. Also the president of the Korean Society of Radiology from 2021 to 2024, and also honorary fellows from the ESGAR and ISMRM, and also the honorary member of the ARRS, SEREM, JSR, and CSR. So this is like our speaker, our expert that we have today who joining us today. And so if you are currently on the VDoctor platform, there's a couple things that I would like you to do. First of all, after you join the VDoctor platform, please put your name on the chat box and join the audience. So by that way, you can type the questions or the comments that you want to share with the speaker, with the panelists on this platform, and we can bring those questions or comments for the discussion. And then like in the meantime, if you have your cell phone with you, please scan this QR code for the evaluations, because we want to know what can we do better and how can we improve the lectures, webinar series, and do the thing that you want to learn, have the lectures that you want to learn, and all the topic that you want to learn. So please scan the QR code, and I will put maybe the link on the chat box on the VDoctor platform too. So the format today is going to be a little bit different from last webinar series. So first, we're going to start with the lectures from Dr. Samuel Brady for like a 15 minutes, and then we're going to turn our session to be a discussion and hear from other people, from radiologists, from medical physicists, and also technologists. So please feel free to, like, if you have any questions or like want to comment, put on the VDoctor platform chat box. So welcome, Dr. Brady. For your talk, we want to hear from you on like how you make this thing happen in your hospital or in like the society or in your country.
Thank you, Tanya. It's been a great experience being with you guys these several months as we've talked about image quality and dose optimization across all the imaging modalities, which can be very difficult to try to do in one lecture. So I appreciate the fact that we took the time and went through each modality over these last few months. For those of you that have stayed with us this entire time, that's amazing. Thank you so much for being here with us. So today, as Tanya mentioned, I am going to speak a little bit about the role of the physicist, but I also want to talk about how the physicist fits inside the broader framework or team that we find in the hospital, that they are, as a team, they are in charge of image quality and dose optimization. All right, there. All right, so when it comes to medical physics, one of the first things everyone
Can you share your
immediately
screen again?
associates.
We lost your screen.
Oh no, okay. Is it back?
Yes.
Okay, apologies. Here in the US, we just celebrated Halloween, so there must be ghosts getting all of our technology today. Anyway, the first thing most people think about when they think about medical physics is testing, equipment testing. And that is, I believe, one of the most important things we can provide for the hospital is to make sure the equipment performs at its peak. And so that we can know that each image, each exam will be the best image quality at the lowest radiation dose. But historically, we've always thought about radiology. As medicine has become more complicated and more integrated across all the various different departments, as a medical physicist, I don't just work in radiology anymore. I service imaging across the entire hospital enterprise. I've been working in cardiology, surgery, orthopedics, gastrointestinal or GI, dentistry, anywhere you can find imaging, be they radiation-based, like CT, X-ray, fluoro, mammography, non-image, non-radiation, non-ionizing, such as MR and ultrasound, and then, of course, nuclear medicine and PET. Some hospitals have those under radiology, others, those are a separate entity. In the end, one of the things I've learned over the course of my career is that medical physicists actually have a unique role in making sure quality control is performed across the entire hospital enterprise. And that is unique because most hospitals, most departments in each hospital employ their own employees to perform their quality control. But a physicist has the ability to kind of go one level higher and make sure it works uniformly across the entire enterprise. Medical physicists do not work alone. In fact, here in the US, it's almost impossible to work alone because of the scope of all the equipment we have. And as such, we have a team. And the team starts with our technologists. Technologists will oftentimes perform routine testing, usually daily, and they almost always will do this before the first patient comes in to make sure the equipment is calibrated and ready for the day. They also support periodic quality control. So now they're checking to make sure the equipment is performing appropriately, weekly, monthly, and in some cases, they'll actually perform the calibration for like the detectors and X-ray, etc., so that everything stays good. This, in my opinion, is probably the most important role. They communicate to the team when they see that the system isn't working properly. We can take lots and lots of images of phantoms, but they don't always show when a machine isn't working well. A technologist that uses this equipment every day, they get a feel and they get a better intimate relationship with that equipment. And so they know when something's not working well. And oftentimes they can alert the proper people, physicists, engineers, to get the system looked at before the problem reaches the patient. And that is very important. Also, they're an integral member of the protocol review committee to make sure all of our protocols stay the same and at the highest quality. Physicians, of course, are an integral part of our quality control team. They will see the images when they go to the reading room. And if there are artifacts or issues that appear in those images, they can then communicate those back to the quality control team. They almost always are important when they first establish a piece of equipment. We install it. We need to build the protocols. We have the app specialists from the application specialists from the vendor that will come in, and they'll work with technologists, physicists, and the physicians to establish the appropriate dosing and quality control. And they're also an integral member of the protocol review committee. So let's talk a little bit more about the physicist role, because of course, this is what I feel very strongly about. Physics quality control doesn't start when we're testing the equipment. It actually starts before we even purchase the equipment. In our hospital, I am a part of the construction team, and the fact that when we design a new room to be remodeled or built from nothing, I'm there to help make sure the equipment will fit properly, that all of the ancillary equipment, such as the sink, the storage closets, are all oriented properly. And then I perform all the safety checks to make sure the shielding in the wall is appropriate to keep everyone safe. Construction people are very good at what they do, and some of them work in a hospital routinely, so they have a good feel for how the room should be laid out. But in the end, technologists definitely and the physicists play an integral role to make sure that when you walk in the door with a stretcher, you don't run into a sink, because you know the flow of the patient, whereas construction people don't quite know. So once we have the room planned and executed, we then, of course, work with the equipment manufacturer when it's time for installation. And then once the system's up and running, we're, of course, a part of the protocol review committee. So we're constantly checking over time to make sure the protocols stay up to date and of the highest quality. The technologists that are performing quality control, we review their quality control results, and we help establish the pass-fail criteria to help inform the technologists when their testing exceeds limits that require us to review the equipment. And then, as always, the equipment testing, which is the hallmark of a medical physicist's job. And once we've tested equipment, occasionally we find when something's not working properly, and then we act as a liaison between the engineers that need to come in and work on and fix or remediate the problem, and then the hospital. And so we kind of act as that in-between person, oftentimes to help communicate what the real problem is, and then to check to make sure the repairs are complete. Additional roles for medical physicists can vary by hospitals and regions. In the US, oftentimes the radiation safety officer is a separate individual. But in a smaller institution or hospital here in the US, oftentimes the medical physicist will be both the physicist and the radiation safety officer. In the end, the radiation safety officer is in charge of making sure the hospital meets all regulatory and legal requirements, so we can keep the lights on and continue to treat and service our patients. They maintain hospital policies, and they act as educators. They help educate regarding radiation risk, because oftentimes our patients will have questions or concerns. And as I've highlighted here, I think it's very important that they're able to also help educate our fellow physicians and hospital staff, many of which interact with and around radiation emitting devices, but they are not educated like you and I. And so they, the radiation safety officer, medical physicist, help provide that education so people feel comfortable as they come into radiology and around all of this equipment, wherever it is in the hospital. We also act as the MR safety officer. And so we provide the safety, we build up the safety program so that we can maintain hospital accreditation. In the US and increasingly abroad, you have the Joint Commission that provides accrediting services for the hospital. We help maintain policies, MR policies, and we ensure, of course, MR safety for all patients. That's mostly making sure that the conditional implants are okay to be in the room or in the imaging bore so the patients can be imaged appropriately. Something that's become a little bit more cutting edge, but something I've had the great opportunity to work on for the last decade, is actually doing something for theranostics, doing radiation dosimetry. So in the nuclear medicine and PET world, we're seeing that we are in kind of radiology, we're doing a lot more therapies, whereas in other places, most of the time you think of radiation oncology that's in charge of this. So as an imaging physicist, I actually perform a lot of the dosimetry calculations for our theranostic patients. And this requires a different set of skills, but it still includes image test, equipment testing and calibration, and some of the other things we'll talk about, such as research and clinical study support. So this is something that you'll probably see maybe more and more in the future as theranostics become more universally accepted around the world. Of course, we need to make sure that all the equipment has the best image quality, but has the lowest appropriate radiation dose for the imaging protocols. And to do that, almost all hospitals now have invested in radiation dose monitoring software. So the radiation dose monitoring software is almost always, at least in my hospital, reviewed by medical physicists. So we can run reports on all the various different imaging modalities. We can identify any imaging techniques or protocols that may exceed our quality control levels. And then we can investigate those and perform the investigation necessary to figure out why, say, a CT head study was too high a radiation dose, and then provide the appropriate education if this was a mistake by the technologist or issue with the equipment, or if we find that it's a protocol that just needs reviewing by the team. In the end, as we've discussed, these the diagnostic reference levels, we are able to incorporate these DRLs into this software platform, which helps us then compare our overall mean or median doses with those of the larger country and even region, depending on which DRLs you incorporate. We provide radiation dosimetry support for staff because occasionally things happen and we need to calculate their radiation exposure to make sure everything's okay. And then finally, just a word about research and development. Not every hospital has the ability to allow their physicists to help do R&D, but this is actually not necessarily just a physicist's role. Not all vendors want PhDs to help develop their equipment. Oftentimes their equipment is developed, but they don't understand how it will react to various different patient populations. And so they may need to get feedback from various different hospitals. In this case, the medical physicists, technologists, and physicians can work as a team to help provide that feedback. And so you are ensuring that this equipment that is still being developed prior to being released can then perform optimally for your patient population. So this creates a team that we've already talked about, and it helps solidify and create a very close-knit group that works together to ensure quality control, even though this is equipment that hasn't yet arrived in the hospital. But eventually, this technology does arrive at the hospital. Having an active research and development program and team in your hospital allows or ensures that your hospital always stays at the cutting edge of technology and will always then receive that technology going forward, which is one of the best ways to keep image quality the best and the radiation doses the lowest for our patient population. Thank you for your time, and I guess we will now discuss this in a group discussion.
Thank you so much, Sam, for give some background on what you have done in the US. If I remember correctly, you mentioned to me before that you normally have like a monthly meetings with our team, right?
As physicists, we definitely meet. I meet monthly with our MR group, and I meet monthly with our radiation or ionizing-based group. And so, yeah, physicists, we meet often. More quarterly, we meet as the quality control team. So every 3 months or so, technologists and physicians are then a part of the meeting.
Out of that, right? Okay, so this gonna bring us to the discussion. Okay, so do we have everyone's here ready? Yeah. So first of all, my first questions that I want to ask the team here, like since we know our role and we want to make this thing happen, so what do you think? What is like the most effective way for the radiologists, technologists, and physicists can work together to optimize the images? And what is the biggest gap or challenges that you have right now on your role in your country? So may I start with like a Professor Jeong Min Lee as like a radiologist, and then like a Dr. Shaw.
Yes, the effective optimization in radiology requires close collaboration among radiologists, technologists, and medical physicists. In Korea, many tertiary centers already employ multidisciplinary teams to refine scanning protocols, conduct regular dose audits, and calibrate equipments for minimal necessary radiation. However, still, despite the national efforts, Korean Society of Radiology, government agencies, and researchers have issued appropriateness guidelines and set diagnostic reference levels for exams. Still, the patient radiation exposure in Korea is higher than desired. Furthermore, many hospitals lack in-house diagnostic medical physicists and structured team meetings, mainly because clinicians, radiologists are too busy and technicians have to finish so many exams per day. So they push it to achieve maximum efficiency during work times. So structured team meetings are very difficult to have. So I think in the future, strengthening everyday collaboration between all three professions is needed to close these gaps. The biggest demand for this is medical physicists in Korea.
The shortage, right? The shortage of the medical physicists in Korea.
Although we have medical physicists in radiology department, many of them are mainly for MR, and medical physicists who specialized for the radiation is mainly work in Department of Radiation Oncology. So in diagnostic radiology department, we don't have many experts, medical physicists in terms of radiation.
So yeah. So what do you think, Dr. Cho? What is like the biggest gap that we have right now?
Yeah, as myself is an interventional radiologist, so I would focus a bit more as an interventional radiologist. So I think intervention. I agree with Jeong Min that a team approach, the collaboration with technologists and physicists in setting imaging protocol is very important. But I would like to stress that in interventional radiology, that imaging protocol cannot applies to all cases, but even for the same cases, they can have very different ways to do it and different ways that to minimize the radiation. So I think as an interventional radiologist, we have to be a very clear mind that during the procedure, you are the team leader in that session, and you have the responsibility to make a good balance to ensure patient safety and procedural success. So sometimes it's very tempting to obtain very good images with very clear images during the procedures, but it may incur increased radiation dose to patients, so it may not be very optimal. So we have to make a good balance. So for example, for the same procedure, even say for a very simple procedure like lung biopsy, we usually do not always need CT guide. For example, for subpleural lesions, we can do it without radiation using ultrasound guided or intermittent fluoroscopy. So I think for the same procedure, you have to tailor make for each patient in order to reduce the radiation. And for the situation in Hong Kong, I think it's also quite similar to Korea, that we are quite lack of medical physicists. So even sometimes we have to share some medical physicists between different hospitals, and also for the medical physicists, their main bulk would be working in radiation oncology, and they are working in diagnostic radiology usually as part-time. So usually they are not dedicated medical physicists working for diagnostic radiology or interventional radiology in Hong Kong. They are usually have a dual role serving the medical oncology, radiation oncology, and diagnostic radiology. So in these few years, we are trying to expand the pool of medical physicists and to increase some senior posts in order to retain the staff and to help us in the radiation safety. So, thank you.
Thank you. Thank you. So let's move to like the Steve, and then we go to like the thing that like we are facing with the shortage of the medical physicists. So we go to like Professor Matsubara at the end. So let's start with Steve on the as like the technologies aspect. What is the biggest gap or challenging that you see right now to collaborate?
Yeah, thank you, Dr. Tanya. I think that one of the biggest challenges I think at the moment is really trying to not necessarily when we're talking about optimization, it's actually almost looking at the image quality and ensuring that we are maintaining our image quality at the same time. And I think from a technologist perspective, there's a lot of different ways to optimize the dose and trying to minimize the impact that has on image quality. And I think what we probably need to do more is communicate more with our physicists to understand which of those elements that you're going to change, which effect that's actually going to have on your image quality, and which one's going to be of least concern, I think, to the change in image quality itself. Because I think the more that we change one element, if that has a massive effect on the image quality, then it may not necessarily be the right choice to make. But I also probably just wanted to highlight as well that if we look at low to middle income countries, and I'm sure that many of us have probably been to a lot of low to middle income countries and looked at the way that they image their patients, and that I think there's a huge gap there in the optimization of doses for those particular ones. And I think where the big gap there is, I think, in terms of the education that we can actually provide to them. And then so there's a lot of work, of course, being done through the IAEA as well as many other groups, and that's really, really good to see. But I think there's still a long way to go.
Agreed. I think so. The education is important. Yeah. Yep. So Dr. Matsubara.
Thank you, Tanya. And I also believe that the most effective way for radiologists, technologists, and medical physicists to collaborate on imaging optimization is through regular team meetings where protocols, those metrics, and image quality are reviewed together. And it is also important to establish a common language so that radiologists can explain clinical requirements, technologists can describe such as operational parameters, and physicists can clarify those and image quality evaluations and something like this. And reviewing imaging cases together and discussing potential improvements as a team can also be very helpful, I believe. And currently, the biggest challenges are often unclear roles between professions and limited data sharing, visualization, and time constraints that make regular discussions difficult. So one of the ideas for me is to address the challenges of staff shortage and time constraints. We can hold such as brief regular meetings, such as 15 to 20 minutes weekly or bi-weekly, such as lunchtime. And our university hospital recently has introduced the style of lunchtime meeting, not after the working time. And sharing those metrics, protocols, images in advance help participants prepare, making discussions more efficient, I think. Thank you.
Yeah.
Yes,
Thank you.
Dr. Tanya, may I? Okay.
Yes, please.
Okay. Let me ask Dr. Jeong Min Lee, because if I recall long time ago when I had my training as a diagnostic radiologist, right, I didn't feel that much involvement of the medical physicists during my training in terms of diagnostic. But when I move around to train, I mean, rotation to radiation oncology, definitely I know that medical physicists involve almost every single step. So when I finish my training, enter interventional radiology, and suddenly I totally forgot about medical physicists in diagnostic radiology. Right now, do we have any, because that long time ago, I'm not sure that whether now medical physicists involved more in diagnostic training or not, because we always know that medical physicists must be there for radiation oncology. But for certain hospital, diagnostic radiology department didn't actually have a real medical physicist. Only when someone come and say, okay, my patient get pregnant and got the radiation, do we need to do anything? And at that time, we call medical physicists. Is that change right now as a university hospital, or should we start from there and then now the team base will be better in the future?
Yeah, actually, the situation in Korea would be similar to what you describe right now. So, as Professor Brady mentioned, the role of medical physicists is critical to make an optimization. However, most physicists in our hospital work for either radiation oncology or nuclear medicine department. So we have two medical physicists, but both of them are MR specialists. So they help MR researches rather than the optimization. So that's the current barrier we are facing too. And also the high imaging volumes and workforce shortage are the two big challenges for radiologists to devote time to protocol improvement. So that's the problem. So in order to tackle that problem, many big tertiary hospitals are setting up a real-time dose monitoring system that automatically collect and analyze those metrics from CT, X-ray, and fluoroscopy as well as IR machines. So all the dose monitoring documents are automatically collected, and then we have our quality control team, and then we analyze the data every 3 months, and then we check our DRL regularly. So that's the current system we are using right now. For national level, there is another barrier, which is the lack of formal incentives and oversight. Everyone knows if we optimize the image quality and the radiation dose as low as possible, the problem is even if we made a lot of effort to lower the radiation dose while maintaining image quality, the government doesn't provide any support or incentives. So the hospital, the president may not have a big interest. So I think in the near future, these kind of things need to be included in hospital accreditation or reimbursement criteria for CT or interventional radiology machines.
So how about in Australia and Japan? How much medical physicists involved in diagnostic radiology in terms of daily practice? Steve or
Can I patch in to make a comment?
Kosuke? Yes, doctor, please.
Yeah, is it okay?
Yes,
Yes,
doctor.
Chris. Yep. Mhm.
Yes.
Yeah.
Yes.
This is a very interesting situation. I've been involved in the IEA and a few on this issue. In fact, in many countries in the world, really the diagnostic or imaging medical physics is almost non-existent. And this is really due to is not in the national legislation. Now, in the basic safety standard, the BSS, there is a provision that we need a competent, clinically qualified medical physicist to do the quality assurance test, to do the dosimetry. If the respective countries do not implement that or include that in their respective national legislation, well, with the legislation or the law on the use of radiation in medicine, then this situation will continue. There's no necessity of getting imaging physicists in doing this QC, dosimetry, and so on. So that is really, we need to engage with the administrators, policymakers to ensure it is built in the national legislation or law. In that case, then we can have the service of the imaging physicists. Okay, thanks.
Yes, Steve, how's
I think,
Australian
yeah,
practice?
Yeah, so in Australia, just to answer your question, I think it's very similar to what I guess to what Samuel described from the US perspective, I think, and in the larger hospitals, we do tend to have dedicated physicists working within in the department who do act as the radiation safety officers. In smaller hospitals, though, that may not necessarily be the case, and they might actually be relying on a third party that they have some sort of business agreement with. But I think what the big gap is between physicists and, say, technologists or radiologists in Australia is that they don't tend to understand a lot of the clinical side of the work itself. They understand the physics behind the work, of course, but sometimes they don't understand the application of that physics when you're actually talking about the clinical work itself. And that can be, I think, detrimental in some cases, not to a huge extent, because I think they do have a lot to learn and they do learn a lot. But this then comes back to that regular communication, those regular meetings that can help to make sure that they do bridge that gap as much as they possibly can.
Any additional comment from Dr. Kosuke?
Thank you very much. And in Japan, the situation is very similar with South Korea. And we do have medical physicists, but most of them work in the fields of radiation therapy or nuclear medicine. And in diagnostic radiology, medical physicists are rarely employed. And in my country, in Japan, it is still quite difficult for medical physicists to find positions in diagnostic radiology. And as hospital management continues to face financial challenges recently for many hospitals, so this situation is likely to persist, unfortunately.
So Danny, you open your video, so something to add?
So I think there's it seems to be quite universal. There's quite lack of medical physicists in diagnostic radiology field. But I think also, although there's a lack of manpower, I think it's very important that to involve them to educate our new trainees. So we usually heavily involve them to teach our new trainees every year and about the radiation safety and IMR safety, and also to the other hospital staff. And I want to raise a question that, because I know nowadays there's a lot of imaging protocols or softwares like AI that claims to can reduce the radiation dose or something with the same image quality. I just wonder if the medical physicists have the role to validate those claims or those. I don't know. I want to hear the medical physicist's opinion. Thank you.
So correct me if I'm wrong. You're thinking that you're going to ask to use AI to help us because we already
No,
a lot of shortage on medical
no.
physicists.
No.
Just
I
kidding.
mean that.
Understood.
I mean that there's some vendors, a lot of vendors have some AI solutions in reducing the radiation dose of that kind of things without compromising the image quality. I just wonder if medical physicist has a role in validating the statements, whether this how much these AI tools can help us to reduce the radiation dose.
I think that's a great question. And that really goes to demonstrate the utility of a physicist. Oftentimes we're more academic, and so we're professors. And so we have the ability to kind of stay more on the cutting edge of technology. We see AI as becoming a very key part of medicine, and especially in radiology and other imaging technologies. The reality is, we need to stay on top of the technology. Oftentimes, we're just barely keeping up with the technology. And that can be very scary in the hospital setting, because then we don't know how it works. And so, are we seeing legitimate results, or are these being, are these manufactured, or these artifacts? And so it's very important for us to stay on top of the technology. And that's why, in my opinion, physicists, they need to work both in the clinic and also on the research side, so that they can stay at least not developing the research, but stay close to the manufacturers so that they know what is going to be released. And if we know that there's a new image quality noise reduction AI tool that's going to be released, hopefully, as a physicist, quality technologist, and physician team, they can work with one of the vendors to help review this technology in a pre-submission format, to then review how it would affect their population. That feedback goes back to the manufacturers, and then they can then review to make sure the technology is working appropriately. So I think we have a very key part to play in making sure novel or new technology is safely implemented in the hospital.
So I agree with Professor Brady, but after installation of AI tools for image noise reduction and also image quality improvement, at the end, what percentage of radiation dose can be saved is dependent on diagnostic performance of the CT exams or X-rays. So for determining optimal radiation dose reduction, I think once again, team approach would be necessary between medical physicists and radiologists. And in terms of using it, our technologist role is critical. So in our hospital, we already reduced radiation dose by 20 to 25% of many CT exams after using AI tools.
Yeah. So I think for me, so I have been practicing in Thailand before, and right now I am in the US. And I think one thing is the common theme for both places is the shortage of a medical physicists, and also the common theme around this region and many places, which means even in the US, in my hospital, we still don't have medical physicists. Even we have more medical physicists compared to the practice that I have done in Thailand. So one thing that I just recently learned now is my CT technologist is my BFF, because you are the one who stop the patient, you stop the inappropriate imaging order, and you are the one who just come to the reading room and tell me, oh, I think they put the order without and with contrast for the children 5 months old. I think it's inappropriate. What do you think? So I think so right now with the shortage situation that we have, I think you need to be friends and you need to communicate clearly with your CT technologists, and they are the one who is like the gatekeeper for you for the appropriate radiation dose and appropriate imaging technique. And then like at the back end, you need to work with your medical physicist in terms of the optimization protocol, which mean like the KV, MA, and those things, which sometimes I'm not that good, but I'm learning to look on the DRL number, to look on the imaging quality, and then like talk to my medical physicist, or like oh, can you do that things better? Anything that we can do better, or can we lower those things? So this is like my approach right now with the shortage of the medical physicists, and yeah, keep connect with the people, and you can ask them on those approach on like how to do things better. That is my take on the current situation that I have right now.
I think you're right, Tanya. I think that I always think that optimization starts at justification and ensuring that all exams are appropriately justified. And this is a really then close communication then between the technologist and the radiologist, I think, in terms of making sure that justification is done. And where we have in Australia, where we have really brought our medical physicists into that, is that I know of a medical physicist that's actually doing a study at the moment on looking at inappropriate referrals within even just for plain X-ray, because a lot of the referrals don't have the appropriate information on the referrals themselves. And I think that then plays a big part as far as a justification of examinations, to make sure that we're not just X-raying and CT scanning every single patient that's walking through the door, that everyone actually is getting the appropriate scan because they actually need it at that time. So it's all clinically justified at the time. So yes, a very, very important component.
To partner, right? Yes. Yeah. So when it's bring to the next questions, since it's a common theme, shortage of of the medical physicists, the long-term plan that we know that we need to have like some regulation, some involvement of the government to do those things, have those things embedded in the program in the hospital. But what is the short-term plan that we can help each other right now, or can set up that things in the hospital? Do you have any idea for the short-term plans before we go to the long-term plan to have enough people, which we don't really know how long that's gonna take. Maybe like not within like a 5 year or 10 years, but for the short term plan that we need to do this thing, besides the AI that we need to like catch up on those things and help on that, what can we do right now as a team to bring this thing together to like have at least like the appropriate justification, optimization for the radiation dose? I want to get some ideas. Yeah.
I would start by saying I recommend, once again, building these teams. Now, a lot of places don't have medical physicists in their hospital. In my personal experience in Thailand, you can have several physicists that may cover multiple hospitals, in which case they can help provide education and supervise quality control managers at the technologist level. And I think this is unique in the sense that we need to ask the hospital to give technologists a role in quality control. So not just the technologist scanning every day, because they don't always have the time to then step back and look at a bigger problem. But really what we need to do is identify kind of quality control managers, even if they're at the technologist level, and give them time. I don't know how much time a day or a week or something to that effect, so that they can then manage the quality control. And then, like I said, working as a team, then there'd be physicians that also need to be given time to work with the technologist to review this. And physicists, if not in the hospital, at least maybe in the region, can then provide some kind of oversight and support. So really it goes back to the management of the department and hospital recognizes the need for such a program, and then allowing it to flourish.
For the my opinion, after follow this 6 episode of optimization, right? It's very eye-opening. Thanks to Sam, but it might be the same as we try to do with the webinar on MR safety, also the webinar on sustainability. I think we all thinking of, okay, how we going to make it happen, right? The first thing I agree with Sam, that the auto education, first awareness. You need to make people aware of, okay, optimization is there, MR safety is there, the sustainability is there, right? So how you make people awareness? First, as Sam has mentioned, the knowledge is the most important, but the knowledge sharing, how we're going to make it more interesting. Right now, we do a lot of webinar, but I'm not sure that the webinar is the only, it may not be the only way that we can make the knowledge interesting. I try to think of how to teach my young generation resident during the COVID, how to make them turn on the camera so I can see their face, something like that, right? So we may need to think of how we're going to move the knowledge sharing more interesting for the new generation. That's the first thing that I'm thinking, awareness and knowledge sharing. The second part is the publication. Right now, as lately, last year, Dr. Evelyn, our past president, have pushed us do quite a numbers of publication to make everyone aware of, okay, sustainability, safety, imaging trend, talking about AI, something like that. So we need to make more publication. So I hope that after this 6 series, Tanya, you need to be the one who coordinate everything and kind of maybe got a call to action on optimization for the region, something like that. That might help. So instead of only webinar, we need to put it more in a publication, and maybe, I don't know, maybe some kind of a challenge as using the social media kind of the event, so people can be part of the awareness of it. That will be the first step, right? But for the team base, it's quite difficult because of the shortage. But as Steve said, that technologists actually in diagnostic is one of the most important part of this optimization. He or she will take a bit of medical physicist role actually in the department, and we will have medical physicists somewhere who will help us in more difficult cases. I think technologists and radiologists first in diagnostic, and medical physicists come in with more difficult and more kind of according to the regulation. This is part of my opinion. Thank you.
I think in addition to educating our resident technologists and medical students, another important part of education is for clinicians, because nowadays hospitals try to maximize the profit from their clinical practice. Therefore, clinicians tend to use more and more exams, radiology exams. And then from a radiologist perspective, some CT exams or X-ray exams are necessary, are not, are not always necessary. So unnecessary exams or duplicated imaging studies in short time interval should be decreased by educating our clinicians. And also as previously discussed, as a radiology communities leadership, integrating this kind of optimization into healthcare policy would be very critical, and then that may all institutions to follow best practice. Maybe government may provide some penalty or incentives if they can create a comprehensive national dose registry to collect the data and benchmark the patient dose data across the hospitals. So I think the two things could be very important. One is educating not only the radiology steps, but also clinicians would be important. And then we need to make a maximum effort to integrate this kind of optimization strategy into healthcare policy. Those two things are very important.
Any comments from
Sorry, Dr. Kosuke, again, is the regulation in Japan state that the diagnostic radiology department must have medical physicists?
No, there's no such a regulation in Japan. And yes, so the number of medical physicists are increasing, but most of them are working in radiation therapy field or nuclear medicine field, not diagnostics.
Okay. Yeah, because in Thailand, we don't have any regulation. We have the regulation on radiation oncology therapy department that we must have a medical physicist, but not for diagnostic radiology. How about in Australia, Steve?
No, not that I'm aware of. I don't think we have any specific requirement for physicists to be within the hospital itself. And I think, like I said before, there are some hospitals that will outsource their have a connection with medical physicists through a third-party group.
Because there's a kind of rumor in Thailand that we might join with the certain regulation bodies that will state that diagnostic department may need a medical physicist, and then chaotic happens because we definitely don't have enough medical physicists in the countries, and every year we still don't have enough training position for medical physicists. And right now in Thailand, few organized few institutions offer the master degree in medical physics. One program, you can be the medical technologist, radiological technologist to enter this program. And the other arm is the engineer. They can also entering the medical physicist master degree. But the one who coming from engineer usually will not work for the hospital. They will work for the kind of industry, other industry, not healthcare. So we have kind of a two tracking on training physicists as well. So still a lot of shortage, and we have no idea when we'll keep up with the new technology, because buying equipment is not that difficult, right? But building training one medical physicist is not that easy, and years of experience is needed when they entering the healthcare industry as well.
Can I make a comment?
Yes.
Yes, please.
Yes, I heard that in Thailand, qualification for medical physicists has become a national license recently. So this could be an important step toward increasing the number of medical physicists in the future, I suppose. Thank you.
Thank you.
Now, the situation, if I may add, in Malaysia, for the imaging or diagnostic, is much better. So there is a requirement, legal requirement, for annual QC to be done by competent medical physicists. So in larger hospitals, particularly the public hospital, they do have in-house imaging physicists to take care of QC, radiation protection, others. Whereas for the smaller hospitals or in the private hospitals, they outsource it to third-party consultant medical physicists to do the job. So all the imaging equipment, they do have the new equipment to be testing and commissioned, as well as annual QC tests, all done by the competent, qualified medical physicists. So in a way, we are much better, but of course, there's still room for improvement. We started the training program almost 27 years ago or longer. So it's have a good start, and we are willing to share our experience with neighboring countries.
Thank you.
Okay. So Tanya, we need a champion for optimization. Can be radiologist, technologist, or a medical physicist. Any will do in any hospital, and then start from there, and then hope that can see your publication on call for action, and then we can give a bit of a checklist. Okay, this is what we should do, the easiest way, and then more difficult way, the more practical, gathering from this 6 episode of our optimization.
That sounds good. We'll do. So I think like in my opinion on this one, so since like it's a shortage everywhere, as I mentioned earlier, and like in the meantime, what can we do right now? So this is the thing that I just recently learned in like the past couple years after I get involved with the radiation dose, with the DRL, because I would say that when I was the resident of fellows, in terms of this knowledge, it's like a very few. I just know that, okay, we can do that one or this one, but I don't have a very strong background on the DRL or like how this thing works, because we were thinking that we have medical physicists to help us, but in reality, it's not enough, right? So in my opinion right now, after I saw those things all the way like for the past 10 years that I has been practicing, I think with this shortage situation, I think radiologists should step up and like at least we should know how to check on the image quality. We need to know the DRL. We need to know what is our optimization, what is a radiation dose that's supposed to happen to the patient. So that's why I think this is the aim of this lecture series, that at least to teach the radiologist to know what is the benchmark on the DRL and what are you doing right now that is match below or above, or what can you do better. That is my take on this one. So that's why we have this optimization series, at least learn how to read the radiation dose and talk in the same language as medical physicists. And by that way, we can integrate like the technologists who is our BFF on the daily practice to understand those things, and then we can connect with the medical physicists to ask them to help with the how to optimize those things. This is like in the short term that we should learn and make this thing happen, in my opinion. And by that way, if we have this thing and we can implement this thing, make it contagious to the other radiologists in the next session, in the other hospital or something, create those like a community that we work together. And by that way, we can understand things better and help improve the quality. Because if we are not be the team leads in this whole process, no one gonna step up. No one gonna step up because like they are also busy, and we are the one who facing this thing like a day to day with the patient and clinicians. That is my take on this one. So open
Yeah,
for
but
other
one thing that I wonder, Tanya, how's he going to make more Tanyas? The one thing that I wonder is particularly pediatric radiologist is the one we should aim for, right?
But we
Because
don't
Samuel, you also work in a children's hospital, right? And Tanya, you're a pediatric radiologist, right? And have found, just like another doctors, Danny, correct me if wrong, the champion in children's hospital in Hong Kong is also a children's pediatric radiologist, right? Because if we go to certain subspecialty in radiology only for radiologists, maybe this group should be our kind of target, that we bring them as a champion and then spread it from there. Because I think a pediatric radiologist is the one who actually the most easiest one who can be persuaded to aware of the optimization on the radiation. This I'm not sure I'm right or wrong, but look around and okay, at least we have both pediatric involvement.
Can I interject and say as well that
Yes,
I think that at the very least is to establish a feedback mechanism between a radiologist and a technologist, and even a radiologist and a physicist as well, because the radiologist is the one who is at the endpoint, who's actually looking at the images and actually seeing that image quality. And if they're not satisfied with the image quality, whilst the technologists and the physicists are trying to reduce the amount of dose, if the radiologist at the end point is not satisfied with that image quality, they need to feed that back to the technologist and to the medical physicist to say, you've made a change to your practice. The image quality isn't sufficient anymore. We need to then look at that and actually see what we can do about it.
Agreed. Yeah. Any more comments? So I think we have maybe like a 5 more minutes for the wrap up things. So I want the final words from you guys. I want the final words from you guys to tell the people who watch this webinar online right now, like a live or like a back again, maybe like on the rerun session on the YouTube channel. I want the final words on the role of individual of you as a radiologist, technologist, and also the medical physicist. How can we bring this thing together for the short term? For the short term, that we need to make the changes right now to help this one right now, not the long term, because long term is like a more policy maker. Maybe go to Dr. Jeong Min Lee, Danny, and Jamari, because like that is a high level from the AOSR. How can AOSR help? But for the short term in the daily practice, to make this thing contagious for everyone want to get involved. I want the final words.
I'll say from a physicist perspective, especially in the Asian, Southeast Asian area, visibility will be important. And so you need to help people understand the importance of your role. And by doing this, you need to highlight quality control programs or projects that showed a successful endpoint where image quality improved, dose reduction occurred, or patient safety was provided. And as that becomes more visible to the hospital, region, regulatory agencies, then you can start to see long-term changes towards more medical physics involvement.
Thank you. Yes, please, Dr. Cho.
And for me, I think my words to take is that no matter how senior you, there's still lots to learn on radiation safety. So I think we have to take a very humble approach that we always have to learn about new things in this area, and we have to collaborate with different stakeholders to improve the safety of our patients. Thank you.
I think we can all agree that that communication and collaboration between all of the relevant stakeholders for imaging procedures, and that includes the clinicians that are referring as well. And I think that if we can establish, like I said before, the feedback mechanism between between radiologists, technologists, physicists, and the referring clinicians as well, where they all get feedback, they all understand what each other's roles are, and they can all understand more about how they can assist.
Thank you. Dr. Kosuke, do you want to?
Okay. I agree with all of the speakers. And when implementing optimization strategies, teams often face practical barriers such as staff shortages and limited time for regular meetings, unclear roles between professions, and insufficient data for analysis. So I already mentioned that to overcome these challenges, establishing the common language and shared metrics is very important, and also regular meetings are really important for establishing a good teamwork. Yeah, okay, thank you.
Thank you. Yes, please, Dr. Jeong Min Lee.
Yeah, I think in hospitals we need to increase the awareness of importance of this optimization strategies by educating medical staffs and also having regular team meetings. And then for society level, radiological societies need to educate the government officials to integrate this kind of optimization strategies into health policies. Those things are necessary to make these optimization strategies as a sustainable option.
Thank you. Professor Ng.
Okay. I'll say a few words on behalf of the AsiaSafe. I'm happy that the AsiaSafe serve as a catalyst, a platform for promoting the optimization strategies. And all the panel speakers have we brought out the point about education, about training, collaboration, the clinical requirements, and all these are excellent strategies. And ultimately, we think about the patient safety. So whatever we do, we should always contribute towards patient safety. The radiological part of it, the radiographers and medical physicists. And also don't forget too that the auxiliary staff, the nurses as well, the engineers, and many others too, they do contribute towards patient safety. And in this respect, we should continue and I'm happy Dr. Tanya is leading this a course. It is to continue to promote, and eventually we hope to see more countries will achieve optimization and eventually leads to a better management of patient safety. Thank you.
Thank you.
I think ASR need to kind of continue doing something like this. We need to commit to this agenda. Actually, we have continued in at least 3 agenda right now. One is the this one is optimization, right? And the second one is the MR safety. And the third one is very important, which related to everything, is sustainability. So these 3 agendas has been continuing in ASR for a while. And I think we will still continuing that. Every one of our office bearer has involved in one or more in these agendas, not only current office bearer, but our past president, immediate past president, and our executive committee members. They are all involved in these 3 agendas, and I think it's a commitment of the ASR that need to continue all the collaboration, promote all the education, and try to make sure that it can be kind of a practical solution in the future. So that's the commitment that ASR will continue. Thank you.
Thank you so much, all speakers, for make this thing happen, making it happen, and put a brainstorming, helping us understand things better, and like the key concept that I learned from all of you guys here. 3 things: communication, education, and regular meetings. So this means that we're gonna come back again, right? Next year or next 2 years on this lecture series, because this is like a 3 main concept to make this thing happen: communication, education, and regular meeting. So we're gonna come back again and see you guys out again on the topic of interest on how can we make this thing better. So which means like the audience, you need to help us on what topic or what you want to learn to have this thing happen or improve the quality of the healthcare, of the radiation safety, of the optimization of the radiation dose in this region. So you please complete the QR code or like the evaluation form that we put on the chat box in the VDoctor platform. By completing that one, we know what we can do better. And thank you so much, everyone. I would like to thank Dr. Jeong, Professor Ng for this support. I would like to thank Sam for helping throughout 6 months, every month. And I would like to thank Steve, Dr. Kosuke and Dr. Jeong Min Lee for helping as a panel discussion, and also Dr. Danny, who is on the road trip right now, but still contribute on this one because this is like a very, very interesting topic that we want everyone to join. And the person that I would like to thank the most, who using the spider web to help connect people together for the whole this webinar series, Dr. Evelyn Ho, the past president of the AOS, who used her spider web to put people together and make this thing happen. So thank you so much, and also thank you, with Doctor, for helping with the platform. I will see you guys again pretty soon. So thank you. Yeah.